Hello, thank you for joining us. My name is Athena Smith-Ford. I'm the Advocacy Director with the Pennsylvania Health Access Network, and this is BAN's Healthcare Reform 101 training. A little bit about us. We're a statewide health access coalition working to ensure that all Pennsylvanians have access to quality, affordable healthcare coverage. We represent a lot of organizations and over 1 million consumers across the state. We're generally recognized by the media, lawmakers on both sides of the aisle, state and federal officials, and others as a credible source of information on what's in the new healthcare law. In fact, we've delivered well over 1,000 of these trainings across the state since the law's inception. Part of our work also involves monitoring implementation at the state level and doing some advocacy work to ensure that the healthcare law is being implemented in Pennsylvania in as consumer-friendly way as possible. So the healthcare law is known by many names. Its official name is the Patient Protection and Affordable Care Act, but it's probably gotten a bit more attention as Obamacare. Some folks may have seen Jimmy Kimmel take to the streets recently. He went around and he asked folks, what do you like better, Obamacare or the Affordable Care Act? And overwhelmingly, people hated Obamacare. They really liked the Affordable Care Act. So just so you know, it's all the same. It was signed into law back in 2010. It was upheld by the Supreme Court as constitutional, except one piece, the Medicaid expansion component, was made optional to states. That's fairly significant. We'll talk about that at the end. This law has been the subject of a lot of attacks and misinformation, and so the work that we're doing here together today to get accurate information out about what's in the healthcare law is critical so that consumers understand the new rights and protections afforded to them. Sometimes it's helpful to take a step back and think about what life was like before healthcare reform. When we saw the decade leading up to reform, premiums were rising much faster than wages, in some instances 5 times faster than wages. Medical bills were the leading cause of family bankruptcy, and the majority of those people who were going into bankruptcy or losing their home because of medical costs actually had health insurance at the time. Prescription drug costs were hurting seniors on fixed incomes. Small businesses were struggling to offer the same kind of coverage as their competitors, and people with pre-existing conditions had no protections. Before we get started on what's in the new healthcare law, I just want to clear up a couple key terms here because I'm going to be repeating these throughout the presentation. A premium is what people who have private health insurance have to pay that insurance company every month in order to maintain their coverage. Sometimes if you get health insurance through your employer, you may pay that premium automatically and may be deducted from your paycheck. Maybe your employer pays the entire cost of your health care coverage, in which case you don't actually pay this. But if you're purchasing health insurance on your own, then likely you are making a contribution to the health insurance company monthly. A deductible is something that you have to pay before your insurance kicks in. So if you have a policy with a $2,000 deductible, for example, the first $2,000 worth of health care costs, you're going to have to pay that out of pocket, and then your health insurance policy will kick in. A copay, just what it sounds like, it's the fixed amount that you pay for every service. So if you have a $5 copay to go see a primary care doctor, then every time you see a primary care doctor, no matter how much that visit costs, your health insurance company pays everything except $5. You pay $5. And a co-insurance is similar to a copay, except it's a percentage amount, and this is something to watch out for. So you may have a policy that has copays for going to see the doctor or for prescription drugs, for example, but when it comes to the emergency room, you have a 10% co-insurance bill. And that would mean that you're going to end up paying 10% of whatever that bill is. So if it's $4,000, you're going to pay $400. If it's a $40,000 bill, you're going to end up having to owe the emergency room $4,000. What we're going to cover today, healthcare law, it's a big law. So we're not going to be able to cover everything in this presentation. We'll talk about insurance reforms, some changes to Medicare and Medicare Advantage plans, the health insurance marketplace, Medicaid expansion piece, the mandate and how it works, and then we'll definitely save time for your questions at the end. A lot of folks think that the only thing the healthcare law does is it helps low-income people get access to health insurance, whereas it definitely does that. The most significant changes the law made were for people who have access to private health insurance. That's the first piece we'll start with today, insurance reforms. So most people who know nothing else about healthcare reform know that this piece, that pre-existing conditions, goes away. But it's such a historic provision that I'm finding as I go out to talk about what's in the healthcare law, folks are still having a hard time wrapping their brain around this one. Should know that insurance companies are no longer allowed to deny you coverage based on your pre-existing condition. It is also illegal for an insurance company to charge you a higher premium based on a pre-existing condition, or to say, for example, we're going to cover everything except your bad heart. All of that is now illegal. There are no more lifetime or annual limits issued on policies. This is a really big deal. Earlier when I mentioned that the majority of medical bankruptcies and home foreclosures tied to medical debt in this country were actually being suffered by people who had health insurance at the time, that was mostly because those folks had hit their lifetime or their annual limit. So you can get yourself a health insurance policy, for example, worth $3 million and think, that's great. When am I ever going to go through $3 million worth of care? Then if you end up contracting a chronic illness like MS or cancer that's rather expensive to treat, you find that you can blow through $3 million worth of coverage in only a few years. And then for the rest of your life, that insurance policy doesn't have to cover any other treatments for you. Plus, these folks were left with pre-existing conditions, so were left uninsurable. The practice of lifetime and annual limits is now illegal. And what's also really exciting is that the practice of rescissions has been finally made illegal. This is when an insurance company sells you coverage. You do everything right. You pay your premiums every month, do what you're told, but when you get sick, they take that coverage away from you. There was actually an insurance company that used to target women who had breast cancer, whose cancer was in remission. Many of these women had hit their lifetime limits, had a pre-existing condition, and no longer had coverage. So this particular insurance company would sell these women a policy. And then if the breast cancer returned, the insurance company would pull the coverage away from them and claim, we didn't know you had headaches, you didn't tell us you had acne, or make up some other ridiculous excuse. That is now illegal. The only way an insurance company can pull your coverage is if they can prove you were trying to commit fraud at the time that you purchased it. And for the first time ever, there is now a whole new list of protections for consumers that want to appeal a particular decision. So for example, say you and your doctor feel strongly that a certain procedure is medically necessary, but the insurance company feels differently and doesn't want to cover it. It used to be that you then needed to appeal that decision, and that appeals process could look like a lot of different things. It could mean calling up one department, spending forever on the phone, being told to fax a letter to that department, trying to follow up with that and hearing, oh wait, no, you were supposed to have your doctor send something else to some different department. That kind of runaround practice is now illegal. An insurance company has to make very clear what the procedure is for you to appeal a decision. And if you are denied that internal appeal, or if you need an expedited decision, if you need the appeal decision in just a few hours, you have the right now to appeal to an ombudsman outside the insurance company. Pennsylvania was deemed unfit to monitor these appeals, so as a Pennsylvania resident, you would be making that appeal to Health and Human Services. If there's any cost associated with the appeal process for you, the insurance company has to pay those costs, whether or not you've granted the appeal. And you're allowed to bring an advocate with you, too. It's a very consumer-friendly provision. Children are now allowed to stay in their parents' plan until the age of 26. It does not matter if the young adult is working. They could be a tax dependent or not. They could be married or not, going to school or not. As long as they are your child and you have family coverage, you can add them on during your next open enrollment period. However, if your 24-year-old child has a baby, the law doesn't mandate that that baby be allowed on your family policy. In Pennsylvania, that baby would qualify for CHIP, but it is just for your, the law just says that the insurance companies have to let people's kids on their plan, not their grandkids, up until the age of 26. And the same is true even if they're not your biological children, but if you married their parent or if you were their legal guardian when they turned 18. So it used to be that if you had health insurance but were visiting a relative out of network and you end up having an accident and you're in an ambulance, you're actually supposed to stop, find your insurance card in the ambulance, call the insurance company on the way to the emergency room and just make sure it's okay that you go to one out of network before they would actually cover you. Turns out that's a little impractical, so you don't have to do that anymore. One of the big things that the law does is it mandates insurance companies have to pay and cover emergency room visits out of network. Women also now have direct access to an OBGYN. Don't need to worry about running through any hoops or getting referrals or anything first. There's something called the medical loss ratio. Sounds kind of wonky, but basically what this mandates is that the majority of the money you spend on your premium payments every month has to get spent on actual care by the insurance company. 80 to 85% of your premium dollars need to be spent on actual care. The 80 to 85%, it just depends on where you live, what kind of plan you have. But basically, if they spend more than 15 to 20% of the money you give them every month on things like advertising, profits, CEO bonuses, whatever else they spend their money on, they are going to have to then give that money back to you in a rebate check. The first year this was implemented, $56 million worth of rebate checks went out to folks in Pennsylvania. It's a cost control measure. There's nothing in the new healthcare law that says insurance companies can't raise premiums. They can. They can raise them as high as they want. But if they don't actually need that money for care, then they have to give it back to you at the end, and that costs them more in the long run. One question that I get asked a lot is who gets the rebate check, and that depends on whomever's paying for the policy. So if you buy your own health insurance and that policy was overcharged, then you're going to get the money back. If your employer purchases the health insurance, even if you make premium contributions through your paycheck, your employer is going to receive that rebate check. However, your employer has to then use that money to somehow benefit you, and they can't just throw you a pizza party and say, well, that benefits them. There's a whole list of, there's a menu of options that your employer can choose from. And these include things like just divvying up the check and giving it to you as a cash bonus, or using it to pay down premiums for the next year, for example. Insurance companies now have to justify rate hikes 10% or higher. This is a really big deal for a state like Pennsylvania. We are typically regarded as having one of the weakest systems of rate review in the country. It is a lot easier for insurance companies operating in our state to raise premiums on policyholders than it is for insurance companies to do that in other states. That being said, we are seeing a lot of rate hikes at 9.5% or 9.8% to get right in under that 10% threshold. But it is good that we're no longer seeing rate hikes at 22%, 28%. Pennsylvania was also deemed unfit to be able to give a ruling on these rate hikes as well. And so, again, insurance companies, when they need to justify those hikes, are going to Health and Human Services for that. Gender discrimination has finally been made illegal in the health insurance marketplace. This means that insurance companies may no longer charge women more than men for the same policy. This is a practice that has been going on for a long time. Age rating is also capped at a 3-to-1 ratio. So that means that insurance companies can only charge their oldest policyholder 3 times as much as they charge their youngest, healthiest policyholder. There didn't used to be a cap on that one. So sometimes somebody who is 56 may be charged, for example, 4 or 5 times as much for the same policy as someone who was 23 years old. And the last big insurance reform is that from now on, people who have private health insurance will be able to get preventive care without a copay. This means that going to an annual wellness exam, getting different immunizations like your flu shot, getting a lot of screenings, mental health screenings, diabetes screenings, and other blood sugar screenings, STD screenings, a lot of cancer screenings like colonoscopies and mammograms. These are the certain kinds of services that you can get now when it seems medically necessary for you, and you can get those without having to pay a copay. And when I say medically necessary, what I mean is that I don't believe you could get, a free colonoscopy every year, as though you'd want to, but within the guidelines, so whatever that is, every 4 years or something like that. After the law was written, the doctors at the Institute of Medicine were asked by Health and Human Services to take a look at this provision and see if there was anything that was being left out, particularly for women. The doctors came back and said, yes, there are some huge oversights, the biggest being birth control. That was controversial, and it wasn't originally included in the law because the technical definition of preventive medicine is to prevent a disease or an illness. And nobody equates getting pregnant with getting sick. The doctors at the Institute of Medicine, however, said, well, look, whatever the definition of preventive medicine is, if a woman wants access to birth control, it's probably a good idea that she has it. So we should include that. And so now the provision includes access to birth control. It's not just the pill. It's any type of birth control that a woman would need, that a woman wants access to. But it also includes a host of other things for women, one of the biggest being breastfeeding, counseling, and supplies. So if a woman wants to be breastfeeding but needs some technical advice on the best ways to do that, or needs getting access to a breast pump, for example, she can now get that through her insurance policy. There's also a long list of things that are included for pregnant women. So if you're pregnant or you know somebody who is, it's a good idea to check that out. It includes things like folic acid and even stuff that's not really preventive medicine. For other people, like urinary tract infection treatment is still included under this for pregnant women because obviously that's preventive for the baby. So moving on, healthcare reform and Medicare. We're in our second bucket here. The biggest thing to know about the healthcare law and Medicare is that there are no guaranteed benefits that are cut. There is all that free preventive care I was just talking about was actually made available to seniors on Medicare back in January of 2011. This is a really big deal. Some of these preventive care services used to be cost prohibitive for seniors on Medicare. A colonoscopy, for example, could have a copay of $400 under different Medicare policies. So now that these are actually available to seniors is a really big deal. The healthcare law actually helps extend the life of the Medicare Trust Fund. I'm skipping down to right here by at least 8 years. The Congressional Budget Office has come back and said, yeah, the healthcare law takes a huge chunk of money and puts it into the Medicare Trust Fund to help extend that another 8 years. But it might have actually extended it by an additional 12 years because of all the money saved from offering seniors that preventive care. The other big thing that the healthcare law does for seniors on Medicare is that it closes the donut hole. And you know what? I need to stop myself and excuse myself. I keep saying seniors when I talk about Medicare. These changes are true for everybody on Medicare, and that includes people with disabilities. The donut hole, for those who don't know, exists in what's known as Medicare Part D, as in dog. Medicare is split up into 4 parts, A, B, C, and D. A and B, that's like going to the doctor and your hospitalization. Part C is Medicare Advantage. It's not even. Traditional Medicare is private health insurance, and we'll talk about that in a second. Part D is the prescription drug piece. The way the prescription drug piece works is that a senior has to pay a senior gets help with paying for their prescription drugs. They pay a certain percentage of brand name drugs, a certain percentage of copay drugs. It's a prescription drug policy. And they get help paying for the drugs up until about $3,000 worth of prescription drugs have been purchased. After that, the next $3,000 to $4,000 worth of prescription drugs, the senior actually has to pay for out of pocket. And that's what's known as being in the donut hole. That's when we hear the stories of having to split pills in half or choosing between food and medicine. After the Medicare recipient comes up and pays for the next $3,000 to $4,000 worth of prescription drugs entirely out of pocket, then Medicare Part D picks up again. So what the healthcare law does is it closes the donut hole entirely by 2020. Donut hole will have gone away. In the meantime, for seniors stuck in it, they're getting a 52.5% discount on all brand name drugs, but the entire cost of the drug actually goes towards their spending to get out of the donut hole. So remember when I said they have to spend $3,000 to $4,000 in order to get out of that donut hole? Say a senior has $100 left to spend in order to get out of the donut hole, and they buy a brand name drug that costs $100. They're only going to spend $47.50, but they are out of the donut hole. There's also a 28% discount on all generic drugs, but only that 28% that the senior is spending, like the actual money that the senior spends, goes to getting them out of the donut hole. In 2012, over 200,000 Pennsylvanians saved over $168 million through this policy. That went up for 2013 because this discount, that 52.5%, has been getting bigger every year. Sorry, I don't have the 2013 saving numbers yet. So we talked about how healthcare reform actually extends the life of Medicare by an additional 8 years. One of the ways it also saves a lot of money in the program is by cracking down on waste, fraud, and abuse. So this isn't very common. It's not as though a lot of doctors participate in practices like this, but what we find is that those individual doctors that do commit fraud are usually responsible for a big chunk of change. So there was one chiropractor in Ohio, for example, who was recently busted for $30 million worth of Medicare fraud. What the healthcare law does is it increases oversight to catch those folks, and then it also increases the penalties that they have to pay back into the Medicare system once they are caught. Medicare Advantage is not traditional Medicare, and I've spoken with a lot of folks. I've spoken with people who have Medicare Advantage that didn't entirely understand this, and I think it's designed in a way where it is somewhat confusing. Basically what happened back in the 90s, the health insurance companies came to the federal government and they said, you guys have everybody 65 and older. That's a big chunk of the business. We would like an opportunity to compete for some of that. We are a private company, so we know that we can offer seniors the same benefits or better for the same cost or less. And you should pay us to do that if a senior chooses to go with us instead of traditional Medicare. And Congress said, sounds like a good deal, let's go. What ended up happening was that in many cases, Medicare Advantage plans did offer the same benefits or better. But in no case were they really able to do that for the same cost or less. In fact, by 2009, we were paying out 14% more per beneficiary on a Medicare Advantage plan than traditional Medicare. I know the slide's a little overwhelming, but basically what we're doing now, the healthcare law, the way it shifts the system is looking at a 5-star rating plan for every Medicare Advantage plan. In order to get a 1 to 5-star rating, the Center for Medicare and Medicaid Services looks at hundreds of categories, everything from chronic disease management to, if I call a 1-800 number, do I get to talk to a human, and is that human helpful? To cost-benefit analysis, and are seniors getting what they pay for when they buy this plan? Over 200 different categories. They rate the plan 1 to 5 stars. 1 to 3-star rated plans go away if they can't bring their rating up to at least 3.5 stars in a couple of years. Those plans are too low quality to be selling to seniors. For also for those plans, they are no longer going to receive that bonus payment, that 14% bonus payment that they were getting from the federal government. 1 to 3 star plans will not receive them. 4 and 5 star rated plans, however, will. They will continue to receive those bonus payments. But from now on, they have to use every dollar of those bonus payments to somehow benefit their seniors. And again, there's a menu of options they can choose from. They can increase benefits, lower premiums for seniors, things like that. And if a senior finds out that he or she does not have a 5-star plan, they can drop their plan at any time of the year and enroll into a 5-star plan and do not have to wait for open enrollment. In order to find out how your plan is rated, you can call Medicare.gov. You can visit Medicare.gov/find-a-plan or call 1-800-MEDICARE. So there was a lot of hubbub around this. Insurance companies sent out letters to seniors who had Medicare Advantage plans and said, your health insurance is going away and it's because of Obamacare. It turns out actually in 2011 that this new system worked out all right. The first year after it was implemented, we saw that enrollment actually increased by 10% for Medicare Advantage plans, so the insurance companies certainly benefited. And premiums fell by an average of 7%, so it worked out pretty well for consumers as well. I'm just going to touch very briefly on some of the aspects around small businesses so that we can spend more time on the piece around the marketplace. Small businesses do not have to provide health care coverage to their employees, and 95% of businesses in Pennsylvania are considered small under this definition. So out of the 5% of businesses that are considered to be large businesses, the majority of those already offer health insurance coverage. So it's really only about 2 to 3% of businesses that are held to this mandate, where businesses of 100 or more employees have to offer health care coverage. That was actually pushed back, by the way, to 2015. And for businesses on the smaller, 50 or more full-time employees have to offer health care coverage. And that was pushed back until 2015. But it was actually pushed back to 2016 for businesses with between 50 and 100 full-time employees. That mandate won't go into effect for another few years. So a small business is defined as 50 or fewer full-time employees or the equivalency of that. So you could actually have 100 or fewer part-time workers and be considered a small business. If you are seasonal, so if you're an amusement park, for example, and you have 300 full-time employees, you're still considered a small business. And franchises, because they are independently owned, also are considered a small business. Small businesses, again, do not have to offer health insurance to their employees. However, if they choose to do so, then they can receive tax credits for up to 50% of the premium costs. I say up to because it's done on a sliding scale, so the smaller the business and the more the employer contributes to premiums, the closer that owner will get to receiving the full 50% tax credit. There's a similar tax credit available to nonprofits up to 25%. There's something called the Small Business Health Options Program, which allows small business owners to purchase insurance for their employees with the same kind of bargaining power as large businesses have. It is not available online for individual business owners this year to go onto. You would have to visit it by calling a 1-800 number or by talking to an agent and broker. Next year, the SHOP exchange will be available online for business owners to peruse on their own. In 2015, business owners will also have the option to choose between I want to give my employers healthcare coverage, or I want to say I'm going to contribute X amount every month, $200 every month to my employees' premiums, and just let them go on to this marketplace and select the policy for themselves. So moving on to the health insurance marketplace. This is a new way that people who are uninsured and small business owners and folks paying way too much for health insurance. People who are paying more than 9.5% of their premiums, or if you just purchase your own health insurance on your own right now, can switch over to buying health insurance through this new health insurance marketplace. Also, members of Congress actually lost their health insurance on January 1st, 2014, and they had to go into this marketplace as well. So when they wrote the law, they wrote it so that every plan sold on this marketplace had to be a qualified health plan. And that means that every plan sold has to offer a whole host of benefits that we'll talk about, the Essential Health Benefits Package. It has to put the language in very clear, easy to understand terms. It has to also, the plans have to also network with an adequate number of doctors and providers. It's basically the kind of plans built up that members of Congress would want to see that they would have access to. Also, for people between certain incomes, there is opportunity to get tax credits and other help to pay for this. So we're going to talk about all of these pieces, including how to get access to it. This is that list of benefits that I was mentioning before. Every plan sold in the new marketplace, and actually every plan sold to the individual market or the small group market, even if it's outside of the health insurance marketplace, from now on has to cover these benefits. Ambulatory service, emergency room, hospitalization, maternity and newborn care. This is a really big deal for Pennsylvania. We were one of the few states left that actually permitted health insurance companies to refuse to cover maternity coverage and to cite being pregnant as a pre-existing condition. So what was happening was that people were purchasing health insurance coverage with no idea that it didn't cover maternity care, or they were getting it through their small business that they worked at, no idea that it didn't cover maternity coverage. Getting pregnant and finding that not only is that not covered, but they also can't go out and buy health insurance because they now have this pre-existing condition known as pregnancy. So this is a really big deal here for our state. Mental health services, which includes substance abuse treatment, prescription drugs, habilitative and rehabilitative services, laboratory services, that free preventive care that I was talking about earlier, and pediatric services. And for children, it also includes preventive dental, so the cleanings twice a year, and vision care as well. Every plan then sold is going to be divided into these four categories: platinum, gold, silver, or bronze. When you buy a platinum plan, that's going to be your most expensive option. The monthly premium is going to be really high, but when you go to see the doctor, your copay is going to be pretty low. And you may get more than just the Essential Health Benefits Package. You will likely get an Essential Health Benefits Package and a gym membership and something else. The bronze plan, you're likely just going to get the essential health benefits that are covered, but it's going to be really cheap month to month. However, your out-of-pocket expenses and your copays are going to be a lot higher. And actually, when advocates were pushing for healthcare reform, many of us advocated against high deductible plans, and we lost that fight. The majority of those are bronze plans. So you may select a bronze plan because it turns out to be pretty cheap, or even free once you get the tax credit month to month. But if it has a $5,000 or $6,000 deductible, it's likely you will end up spending a lot more money on that plan throughout the year than if you selected, for example, a silver level plan. There is a fifth option known as the catastrophic plan. This is for those young invincibles, folks 30 and under, or people who receive a financial hardship exemption and actually don't have to purchase health insurance. They can either then not purchase health insurance and be exempted from the mandate, or they can get themselves this catastrophic plan. It is a high deductible plan, but it covers 3 primary care visits and the free preventive care. Once the deductible is met, all the other essential health benefits are covered. For individuals making between 1% and 400% of federal poverty, there's going to be some help to pay for coverage. Sometimes that 1 to 400% is hard to really get your brain around, federal poverty level. So this is just an example. An individual at 100% of federal poverty makes around $11,500 a year. At 400%, it's about $4,000 to $6,000 a year. Sometimes it's helpful to see what that looks like as an hourly wage if you're working full-time or part-time. A household of 4 at 100% of federal poverty is around $23,500, or at 400% around $94,000. So if you're making closer to 400% of federal poverty, you're not getting a lot of help to pay for your health care, but you'll get some. And at 100% of federal poverty, obviously, you'll get a little bit more help to pay for it. That help, paying for your health care premiums, is known as a tax credit. And the way the tax credits work is that they're paid directly to the insurance company so that you can just pay your share of the premium then every month and don't have to worry about it. The marketplace is going to let you know how big your credit is. So again, you don't need to worry about that, figuring that out. It's based on the silver level plan so that that's affordable to everyone, but then you have the option. You can take that tax credit and purchase the bronze level plan, and maybe that's free then. Maybe that entirely covers your monthly premium. Or say, you know what, actually I can afford an extra $20 a month. I'm going to upgrade to the gold plan. Tax credits, also, this is important to note, are based on your projected income. When you sit down to enroll in the marketplace, you're telling the marketplace, this is what I expect to make in 2014. This is where I expect to be in the scale of federal poverty level. So figure out for me how much my tax credit should be and how much I should have to pay month to month this coming year on my premiums. If you think you're going to make $15,000 in 2014, but you end up making $20,000, then at the end of the year when you do your taxes, that's all going to get sorted out, and it'll become evident that you actually received a tax credit larger than you are eligible for. You'll have to pay some of that money back at the end of the year. How much you pay back is again done on a sliding scale depending on where you fit in federal poverty. If you end up making $48,000 a year, making more than 400% of federal poverty, you'll actually have to pay back the entire tax credit. If you're lower on the poverty level, then it's just a couple $100. But still, a couple $100, if you were expecting to get money back, can come as quite a hit. So this isn't a big deal once it's been flagged for you, but it is something that we like to flag for folks. If you see that your income is fluctuating and changing, go back to the marketplace, talk to a navigator, go to healthcare.gov, call a 1-800 number, and just let the marketplace know my income's changing. There's more help. So those tax credits that we were talking about, that's to help people pay for their premiums every month. For people who make less than 250% of the federal poverty line, which is about $29,000 a year for an individual, $59,000 a year for a family of 4, they can actually get help paying for their out-of-pocket expenses, lower deductibles, lower copays, things like that, as long as they're enrolled in a silver level plan. On all the plans, there's also caps on out-of-pocket expenses no matter where you are at the income level. So how big the cap is depends on where you are on the income level. These caps are set very high, and they aren't intended for the average user. Most people will never hit them. Once the caps are hit, though, then the rest of your out-of-pocket expenses are picked up by the insurance company for the year. Again, most folks are never going to hit the caps. It's not intended for you. It's intended, it's not intended for the majority of people. They're intended for folks, for example, who have cancer and have to go a couple times a week for a chemo treatment, which has a very high copay. And this way, those individuals won't be going bankrupt or be under significant amounts of financial strain, even though they have health insurance. So just to recap, members of Congress, uninsured people, small business owners, folks purchasing health insurance on their own or who kick in a lot for their paycheck for it, can go into this new marketplace. There is help available to purchase the health insurance depending on where your income falls. Every plan that is sold there has to meet certain quality standards, including offering 10 essential benefits. And you want to watch out for income changes and just let the marketplace know if that's happening. But how do you get it? Well, You can visit healthcare.gov. We understand that when this was first coming around, the site wasn't as helpful. In October, there was obviously October, November, some enrollment issues on healthcare.gov. But that has been fixed. I can tell you I've been having tremendous success enrolling folks on the site. And it's been really great for me, too, just as a personal note, to be able to enroll individuals and sign them up for health insurance at 21 cents a month or $23 a month. Really good coverage. So that's been great to see. If you don't want to do it online, there are some other options. You can, for example, call 1-800-318-2596, which is the Marketplace's hotline. That's available 24/7. The average wait time is about 3 seconds or so. They do have customer service representatives fluent in English and Spanish, and then they have a language line that they can use for 150 additional languages. Another way to get access to the Marketplace is to talk in person with a navigator or a certified application counselor. For you, the difference doesn't really matter between a navigator and a certified application counselor. Navigators are charged with having to go out to the communities to do this. Certified application counselors aren't getting federal money to do this, so they don't have to do that stuff. They are just, there are a lot of volunteers, a lot of organizations eating the cost, taking it up upon themselves to say, this is important, we want to play a role, we want to help people get enrolled. And so they become certified application counselors, and they have to go through all the training and meet certain privacy standards too, just like navigators. In order to find someone near you, you can visit localhealth.healthcare.gov. Just a fair warning, insurance companies are allowed to be certified application counselors. They have to disclose to you if they have any conflict of interest, but they are allowed to be CACs. If that makes you uncomfortable, you can go to localhealth.healthcare.gov and just look at who certifies that CAC, that certified application counselor. Is it an insurance company, or is it a church or a nonprofit organization? If you can't find one near you, or you have a relationship with STAN, you've been turning to us the past 4 or 5 years for information on healthcare reform, you're welcome to call us. We have a lot of certified application counselors across the state. Our 1-800 number is 1-877-570-3642. And usually it'll be Patrick. He is our lead certified application counselor who will call you back. Sometimes other folks will too. And you'll likely get a call back the same day, or at least within a day of leaving a message on that number. You can also, I'm sorry it's not on here, email helpline. That's HELPLINE at pahealthaccess.org. So right now we are in the initial open enrollment period. It's going to end at the end of March 31st. For folks who sign up for coverage today, their coverage isn't going to take effect until April 1st. For coverage to take effect the first day of the following month, you have to sign up between the 1st and the 15th. And then if you sign up between the 15th and the last day of a month, then your coverage takes effect the first of the second following month. So that's a little confusing, but basically if you signed up for coverage on February 5th, then it would have taken effect on March 1st. But since right now it's the end of February, your coverage won't take effect until April 1st. Once open enrollment closes, you can still get access to the Marketplace if there is a special qualifying event. If you don't sign up for coverage right now, and then come May, you start getting sick a lot and think, I should really have health insurance, that is not considered a qualifying event. Because the law does away with pre-existing conditions, it felt that it needed to have special enrollment periods just so that people were not enrolling in health insurance once they actually needed it, but so that healthy individuals would too, to help keep the premiums down. These are the examples of what currently counts as a qualifying event. It includes things like having a child or moving or losing your job, exceptional circumstances like a natural disaster in your area, etc. So the final component of this I want to talk about is the Medicaid expansion piece. And this is this is fairly significant, and this is the Supreme Court ruling that we were talking about earlier today. The healthcare law was designed so that individuals making between 1% and 400% of federal poverty would get help purchasing private health insurance in the new marketplace. We were just talking about that. They get tax credits to help pay for premiums. If they make less than 250%, they also get help paying for all the out-of-pocket expenses so that they can purchase private health insurance. Individuals making less than 138% of federal poverty, which is about, you can see there, almost $16,000 a year for an individual, or $500,000 a year for a family of four. Everybody making less than that income was supposed to go into the Medicaid program. They just left a little wiggle room there between 100 and 138%. Then there was this law that, then there was this lawsuit that went all the way up to the Supreme Court challenging, is the healthcare law constitutional? And the Supreme Court ruled, yes, it is constitutional, yes, the mandate is constitutional, but this Medicaid expansion piece should be optional to states. Pennsylvania has still not taken this option. All of our surrounding states have, but because Pennsylvania has not, everybody making less than 100% of federal poverty actually cannot get access to health care at all. There's nothing in the law for that because the subsidies start at 100%. So folks making between 100 and 138% of federal poverty, those individuals should be able to go into Medicaid, but at least they can get subsidies to purchase health insurance in the private marketplace. But somebody making 50% of federal poverty line, there's no help for them right now through the new healthcare law if they're living in Pennsylvania. Sometimes it's helpful to understand how medical assistance currently works in our state. It's a state-federal partnership, and it's paid for by a blend of state and federal dollars. We get about 54 cents back on the dollar that we spend on actual care for folks enrolled in our Medicaid program. In order to get access to Medicaid, it's actually not an easy thing to do. There's a huge misconception that if you're low income, you can get Medicaid, and that's actually not true. You need to be very low income and also fit into another qualifying factor, like be a child or be a parent or be a low-income senior or have a disability or be pregnant or things like that. It's just me. I'm a woman. I am single. I don't have any children. I'm under the age of 65. I don't have a disability, but I make $10,000 a year. I cannot go into the Medicaid program. Many of these people are working. They're just working low-wage or temporary or part-time jobs that don't provide health insurance benefits. So what the new healthcare law offers to Pennsylvania is 100% match rate. It means that the federal government will give our state and pay for the entire cost of care to give low-income Pennsylvanians access to Medicaid for the first 3 years. Starting in 2017, this will slowly go down until it's at about 95 cents on the dollar. And then in 2020, it steadies out to about 90 cents on the dollar is what we will get back. So we'll have to be kicking in by 2020 10% of the cost of actual care. Pennsylvania will also have to pay the entire administrative costs of this. I should mention that this is huge. Being able to open up Medicaid to just an individual who makes less than 138% of federal poverty, boom, you make less than almost $16,000 a year, you qualify for Medicaid, you don't have to fit into any of these other categories. That's huge. When we talk about the new healthcare law giving access to health insurance, to healthcare coverage for tens of millions of adults, it was mainly through the Medicaid expansion piece that was going to happen, not through the marketplace. Who is it that makes less than 138% of federal poverty, or around $16,000 a year for an individual? Hundreds and thousands of Pennsylvanians. There are about 600,000 Pennsylvanians who make this income level, and there are about 400,000 Pennsylvanians that actually make less than 100% of federal poverty, which means that they're falling in that Pennsylvania gap and aren't eligible for coverage right now. A lot of them, hundreds of thousands of them, are working moms and dads. There's a lot of veterans that fall into this category as well. These people are overwhelmingly working. 75% of folks qualifying for expanded Medicaid have at least one full-time worker in the household, but they're working jobs that don't provide health insurance and don't pay enough to buy it in the private marketplace. You can take a look at this map here and see what county you're in and the percentage of people in your county that were uninsured that would qualify for Medicaid expansion. We apologize, the white counties, we're still looking to get the data on those. So I'm keeping this part concise, but individuals, if you have follow-up questions, you want to see some of these studies, you want to talk more in depth, please feel free to let me know. A host of independent fiscal impact studies have been done on this issue, looking at, Pennsylvania has to pay eventually up to 10% of the cost of care. We have to pay for all the administrative costs of enrolling these hundreds of thousands of individuals. Is it worth it financially to do it? We know it's morally the right thing, but is it financially the right thing to do? And it turns out, overwhelmingly, the answer is yes. Pennsylvania's own independent fiscal office looked at this and said it is a huge economic win for Pennsylvania, and a few other independent fiscal studies, all the ones that were done, concluded the same thing. It's a lot more expensive for Pennsylvania taxpayers, basically, to be paying to have hundreds of thousands of people uninsured than it is to accept federal dollars to give those folks coverage. This will also create 35,000 new good-paying jobs, and that's actually the lowest estimate. Some studies say it's closer to 45,000, and then depending on what study you look at, it's either going to be about, that's going to generate $3 billion in new tax revenue, maybe $5 billion. Again, it depends on what study you're looking at. But yeah, this is going to be a really good thing for Pennsylvania. That's why states all around us have taken the Medicaid expansion. So if you're making 50% of federal poverty and you live in Ohio, you have health care coverage today. But if you live in Pennsylvania, you don't. Obviously, hundreds of thousands of Pennsylvania lives are at stake. The Pennsylvania hospitals are also set to lose a big chunk of change that they get to help pay for uninsured people showing up at their door. So when uninsured folks show up in the emergency room and can't pay the bill, that cost gets paid for by taxpayers, and also the hospitals have to just eat some of that cost. But the federal government gives money to hospitals to help make that a little easier for them. The federal government's giving a lot less money to hospitals because all of these folks were supposed to have health insurance, either through Medicaid or the marketplace. If our hospitals lose that money and hundreds of thousands of people are still showing up uninsured, it's going to be devastating for a lot of them. It's going to cost our state about $1.64 billion over the next 10 years. Again, that's according to Pennsylvania's Independent Fiscal Office, and that's a lot less than our state is going to save, and a lot less than the new revenue we're going to generate from taking this opportunity. So what's been happening recently is that instead of expanding Medicaid under the new health care law, the governor has decided to come out with this plan called Healthy Pennsylvania. Healthy PA is not expanded Medicaid in the traditional sense, and it actually asks for a series of waivers that to change how we currently use our Medicaid dollars. Since we want to change how we currently use our Medicaid money, we have to go through a very lengthy waiver process. The proposal will change the current Medicaid program, not just the program for all these new eligibles. So it's not just the new 400,000 folks that would go into a new kind of program, but folks who are currently on Medicaid would be subjected to some fairly significant and dangerous cuts, namely seniors, people with disabilities, and pregnant women. There are going to be limits, for example, on durable medical equipment. So a low-income senior citizen needing a mechanized wheelchair. Not very many seniors need a mechanized wheelchair, but if you do, the limits wouldn't cover that. There are limits on, there are dangerously low limits on diagnostic testing and laboratory work. So if you have a blood disease, you're a senior with a blood disease, or you're a pregnant woman or an adult with a disability, you very well may blow through the $350 lab work limit early on in the year. and be left to try to come up with the rest of that out of pocket. So advocates are very concerned about that. There's also work requirements which don't make any sense because we know the majority of these people are working. And it's just going to be expensive to hire folks in Pennsylvania to prove that the majority of these people are working, which we already know. The work search requirements that folks would be subjected to are also troublesome because it has to do with going onto a job bank online. So it presumes that individuals have access to the internet or can get to the job gateway location, and usually there's at least one in every county. But for those rural areas where internet access is harder to get, especially if you're very low income and you can't drive an hour or two to the job gateway search site, I mean, it's troublesome. There are premiums that start at 50% of federal poverty. For individuals who make only a few $1,000s a year, you don't likely have not only the money in your budget, but it logistically doesn't make a lot of sense. How are folks going to pay that? They don't have a checking account and they don't have a credit card. And who are we going to hire at DPW to sit there and collect the $13 a month premium payment? So it sets up a lot more bureaucratic red tape, but then, and it adds a lot more expense to the state, but it's also troubling because there are lockout periods. So for individuals that aren't able to get onto the job gateway site or aren't able to make their premium payment that month, they could actually end up losing their coverage for 3 months, 6 months, 9 months. Like I mentioned, there's this lengthy waiver process. Part of the waiver process, too, is not only because of the cuts and the changes to the current Medicaid program, but also because all the newly eligible, those 400,000 folks or 600,000 people, instead of just putting them in the Medicaid program, this plan seeks to put them in private health insurance. Private health insurance is actually a lot more expensive than Medicaid. Medicaid has an efficiency rating of 96%. So 96% of all Medicaid spending gets spent on actual care, whereas we know, because we were talking, I know, almost an hour ago, about the medical loss ratio, that 80 to 85% of premium payments have to get spent on actual care for private health insurance. So for the first couple of years, it's not a big deal. Federal government's footing the bill. But come 2017, when Pennsylvania taxpayers are kicking in 5%, it is going to be a lot more expensive to kick in 5% for the private health insurance option than it would be to kick in 5% for issuing Medicaid coverage. The last thing I want to talk about is the individual mandate. I saved this for last because it's easier to understand once we talk about the Medicaid expansion issue. So individuals who choose not to get coverage will have to pay a penalty, and the penalty is going to be paid when you pay your taxes. So when you go to pay your 2014 taxes at the end of the year, in 2015, that's when you'll pay your penalty for not having had coverage in 2014. That penalty will be $95 or 1% of your income, whichever is greater. That goes up to $325 or 2% or $695 or 2.5%. There are exemptions. Not everybody is held to this mandate. If you belong to a health sharing ministry, so for example, nobody's going to make the Amish sign up for health insurance. If you are only uninsured for less than 3 months, you cannot find coverage that costs less than 8% of your income, financial hardship exemption I was talking about earlier. Or if you would qualify for Medicaid expansion, but you live in a state that isn't expanding, you are exempt. In order to be exempt, especially under that last exemption there, you need to fill out an exemption form or seek to apply for health insurance through the marketplace and then be told, oh, you make Medicaid, you're actually making less than 100% of federal poverty. So for individuals, if you are working with people that may need help filling out those forms or with that process, again, please send them to us. Our 1-800 number was up on the screen before. Just going to go back to that again. 570-3642, 1-877-570-3642. And we would be happy to help them with that process. So the next steps, encourage you to sign up for our emails. That shouldn't be too surprising, but we will let you know when there are fast-moving changes with the Medicaid expansion fight, when if open enrollment period is changed or extended, those kinds of policy updates we release fairly quickly as it's happening. We'll also continue to offer free webinars. We've got policy calls, a series that's really interesting that you're welcome to get in on. Action alerts, much more. We're asking that you call your state legislators in Harrisburg and the governor and tell them to expand Medicaid today. We are also available on Facebook and Twitter if you're looking to connect with us that way. We ask that you tell your friends and family what you learned and that you make an effort to share this information with your community. So this is a presentation that, like I said, thousands of these have been given. It has become so popular that we have trained over 90 people across the state to deliver this presentation, so we can get you either if not a FAM staff, then a FAM certified health reform trainer to come to your organization or your community and talk to folks about what's in the healthcare law. We can also tailor this presentation specifically for you to talk about the pieces of the law that might be most relevant to your constituency. And then again, we also have certified application counselors. If you're viewing this before the end of March 31st and would like somebody to come to your organization and help to enroll individuals, we're happy to do that as well. See my direct contact information there on the bottom. Please feel free to contact me for more information, resources, follow-up questions, etc. That's what we're here for.